Good morning, everyone, and thank you for attending our Grand Rounds lecture. This is a Wallerstein lectureship. This endowment is established through a generous gift by her husband, Ben A. Wallerstein, and her children, Nancy Wallerstein Miller and James M. Wallerstein. It was her family's intent to memorialize the life of her beloved Diane by creating the legacy that will support education of medical students, faculty, and researchers at MCV for VCU. I'm pleased to introduce our speaker, Dr. Michael Shapiro. Dr. Michael Shapiro is faculty and professor of cardiology and molecular medicine at Wake Forest University. Following his cardiology fellowship, Dr. Shapiro pursued advanced training in cardiovascular imaging at Mass Gen Hospital. Since then, his career has been devoted to the study of lipids, atherosclerosis, and prevention of cardiovascular disease. He currently serves as the director of the Center for Prevention of Cardiovascular Disease at Wake Forest University and as co-director of the NIH T32 Fellowship Program in Cardiovascular Disease Epidemiology and Prevention. His research spans translational science, cardiovascular epidemiology, and clinical trials of lipid modulating therapies. His pioneering work on PCSK9 physiology and related therapeutic interventions has established him as a leader in this field. Dr. Shapiro also holds numerous leadership roles in large international clinical trials. He's highly regarded for his commitment to mentorship and has played a pivotal role in guiding the careers of many trainees who have gone to achieve significant academic and clinical success. We're very grateful to have him speak here at Grand Rounds today. At the end of the lecture, we'll leave time for any questions. Thank you.
Thank you very much. Really appreciate that kind introduction and really delighted to be here with you this morning. It's really an honor to have the opportunity to provide this lectureship. So I'm going to be talking about the whole PCSK9 story. Many of these features will be familiar to you, but I want to really take you back a little bit and give you some of the details of really how this has provided a blueprint for intelligent drug discovery and give you a peek at a very cool future. Here are my disclosures. So to frame the conversation, we first need to understand that lipid-lowering therapy as a clinical therapeutic really came into its own in the 1980s, obviously with the development of the statins. We had the first statin approved in 1987, that was lovastatin, and then in 1994 was the first randomized controlled trial, statin megatrial, the 4S trial that showed significant cardiovascular event reduction with simvastatin. But it's really in 2003 with the discovery of PCSK9 and its ensuing development as a therapeutic that it really has transformed our ability to take care of the patients who are most challenging in terms of severe hypercholesterolemia and ASCVD risk. And of course, as you know now, we have a small interfering RNA molecule that helps to lower LDL cholesterol by preventing production of PCSK9 and has really kind of advanced the approach to treating patients. And we'll conclude with some exciting new approaches to antagonizing PCSK9. So I've been interested in the prevention of cardiovascular disease for quite a long time. And it occurs to me that atherosclerosis is both preventable and treatable. So it seems surprising that it remains the leading cause of death and disability worldwide. And in fact, I'd mentioned that in 1994, when the 4S trial was published, and there were these beautiful results for the first time, major MACE reduction with statin versus placebo, there were some very high-profile figures, including Nobel laureates, who prophesied, that's it, that's the end of coronary disease. We've got it. The statins are here, no more. Statins have been obviously one of the major clinical advances of the 20th century, but they haven't obviously been a cure for coronary disease. What we see with statins across the statin megatrials is about a 30 to 40% relative risk reduction in MACE, which means about 60 to 70% of people on statins still go on to have recurrent events. And of course, this has begged the question, if we had the ability to lower LDL cholesterol more effectively, would that be productive? And fortunately, we're in a renaissance in prevention of cardiovascular disease, especially with regards to lipid therapeutics. So we have now a lot of new non-statin therapies that are already in the clinic, but there is a whole pipeline of very exciting drugs that I'm going to be talking about, but I'm going to be specifically focused on PCSK9 therapies, but please be aware that there are other therapies that are in development to modulate lipids as well. So I want to just take you back to our understanding of cholesterol metabolism in 2003. At that time, all we understood about cholesterol metabolism is it took place squarely within the hepatocyte. So you have an LDL particle in the circulation. It binds an LDL receptor that's in red on this cartoon rendering of the hepatocyte. The binding of the LDL particle to the LDL receptor triggers something called receptor-mediated endocytosis. And so now you have that LDL particle, LDL receptor complex brought into the cell within this endosome. And that endosome has a proton ATPase on its surface. So there's progressive acidification of the internal contents of the endosome. And when it reaches a critical pH, there is a decoupling of the LDL particle from the LDL receptor. And this is actually a beautiful physiology because it's much more energetically favorable to just recycle the LDL receptor back to the surface rather than constitutively synthesize more LDL receptor protein. And in its 24-hour lifespan, the LDL receptor can recycle about 100 to 150 times. So one LDL receptor can clear up to 150 LDL particles. So the LDL receptor goes back to the surface, it engages more LDL particles, and of course the LDL particle stays in that endosome, fuses with the lysosome, and then its cholesterol content can be used in myriad ways depending on the needs of the cell. That's our understanding, and most of this was generated from studying individuals with familial hypercholesterolemia. You'll recall familial hypercholesterolemia is a common autosomal dominant hypercholesterolemia. It is usually due to defects in the LDL receptor gene. And so if you imagine that individuals without FH have an LDL cholesterol of about 100 to 150, individuals who are heterozygous, the more common form of FH, would have half the capacity, half the functional LDL receptors. So their LDL cholesterols are typically going to be 200 to 300. And if not identified and treated starting at an early age, of course, they're set up for early aggressive coronary artery disease. I bring this up because in 2003, there was a French kindred that was identified who clearly had autosomal dominant hypercholesterolemia, looked like typical heterozygous familial hypercholesterolemia. And they sequenced these individuals, and they didn't have any mutations in the LDL receptor gene. They also looked at ApoB. That was the other canonical gene. ApoB is the main protein constituent on all of the atherogenic glycoproteins. It's what binds to the LDL receptor. No mutations in ApoB either. They did identify a new gene, PCSK9. And it is just serendipitous that PCSK9 is the 9th member of the proprotein convertase acetyllysin family, was identified just months before. But with its identification, nobody had any idea what it did. Well, now we see PCSK9 and we see very high cholesterol. That's a pretty important clue. And so that led to an intense investigation, and that allows us to complete our understanding of cholesterol metabolism. And it's not just squarely within the cell. Now we have another actor. The LDL particle is the primary ligand for the LDL receptor, but PCSK9 is another ligand for the LDL receptor. So this whole process starts the same way. However, if PCSK9 is also bound to that LDL receptor, when this ternary complex is brought into the cell, PCSK9 interferes with that natural recycling loop that I just talked about. It prevents the LDL receptor from going back to the surface of the cell. And it's on a suicide mission to kill the LDL receptor. This whole ternary complex, LDL particle, LDL receptor, PCSK9, is brought to the lysosome for destruction. This, of course, has the effect of reducing the amount of LDL receptor that's on the surface of the hepatocyte, reduces the ability to clear LDL from the circulation. Now, very interestingly, as this was put together, it was recognized that the mutations that were found in this French kindred were gain-of-function mutations in PCSK9. They made PCSK9 work better. Well, as you may know, gain-of-function mutations aren't very common. Usually mutations break genes. They're loss-of-function mutations. So some very smart people said, well, if there are naturally occurring gain-of-function mutations, there must certainly be naturally occurring loss-of-function mutations, and that's what people look for. They looked at some of the large population-based cohorts, and they looked at the individuals with the lowest LDLs below the 5th percentile to, basically find the individuals who would be most likely to have loss-of-function mutations in PCSK9 if they exist, and that's what they found. And interestingly, as you can see in the Copenhagen City Heart Study, they identified the R46L. That's the most common loss-of-function mutation, and it's in a few percent of the population. It's associated with very modest LDL cholesterol reduction, 12%. I mean, this is really equivalent to very low intensity statin therapy. However, it's associated with nearly a 50% reduction and cardiovascular disease, which of course makes sense because you have modest reduction in LDL from birth, right? So that's a much more productive way of reducing risk of ASCVD. Is lifelong reductions in LDL is going to be much better than to wait for somebody to have a heart attack and then get very serious about LDL cholesterol reduction, which we often do. As you can see in the US cohorts on the bottom, there were other loss of function mutations that were identified, and they were associated with about a 30% reduction in LDL cholesterol. And this almost inoculated individuals against atherosclerotic cardiovascular disease, lifelong reduction of 90%. So, of course, this makes a perfect story for a therapeutic target. You have people who have gain of function mutations, who have high cholesterol and high risk for cardiovascular disease. You have, on the other hand, individuals who have loss of function mutations in PCSK9 with lifelong low LDL, lifetime low risk of cardiovascular disease. And importantly, these individuals with loss of function mutations in PCSK9 are healthy. They have perfect cognition, perfect reproductive capacity, nothing to suggest that this would not be a good therapeutic target. And of course, you know the rest of the story. Of course, we have the monoclonal antibodies, 2 of them to PCSK9. And I want you to just wonder for a moment, I'll get back to this, why did we start with monoclonal antibodies? When do we ever start with antibodies as the first approach to a therapy? We'll get back to that. So here are the phase 3 cardiovascular outcome trials with the 2 PCSK9 inhibitors. Evolocumab was published first. That's the Fourier study. Almost 28,000 patients with stable atherosclerotic cardiovascular disease on great background therapy, then randomized to evolocumab versus placebo. Alirocumab on the bottom. This is the Odyssey outcomes, also published in the New England Journal of Medicine the following year in 2018. This was in a higher risk group. These were people who had an ACS within a year of randomization into this trial. And both of these studies showed that the PCSK9 inhibitors lowered LDL cholesterol by 60%. And they had this exact same outcome effect. They reduced the MACE outcome by 15%. So, and this is on top of very good high intensity statin therapy, aspirin and everything else. And in less than 3 years, you're able to show this difference. So of course, this got integrated into our 2018 AHA ACC cholesterol guidelines with regards to recommendations for PCSK9 inhibitors. Individuals with established ASCVD with LDL cholesterols of 70 or greater, all who are on maximally tolerated statin therapy and ezetimibe, consider a PCSK9 inhibitor. Actually, it's a class 1 recommendation. And individuals with familial hypercholesterolemia who still have an LDL cholesterol greater than 100 despite max tolerated statin therapy and ezetimibe. So, as I mentioned, the 2 cardiovascular outcome trials were very short. Fourier median 2.2 years, Odyssey outcomes 2.8 years. And so very impressive results, but it doesn't give us any insight into what the long-term safety and efficacy of these drugs are. So more recently, we have the results of the open label extension study. So those parent trials were about 3 years, and now you add another 5 years. Okay, so this is the open label extension of Fourier. Fourier initially had 28,000 people in the parent study. 6,600 individuals were included in these open label extension. And now when you're in the open label extension, everybody gets evolocumab. So you have the people in the parent study who were originally randomized to evolocumab for 3 years, and they continue in the open label extension on evolocumab for another 5 years. Versus individuals who were originally randomized to placebo in the parent study for 3 years, and now they get switched at the 3-year mark to open label evolocumab. And what this taught us is that you can never catch up in terms of risk reduction. The individuals in red who got evolocumab straight for 8 years continued to do better. And despite the fact that there was only a delay of 3 years to adding evolocumab in the open label extension, their risk was always higher in people who first had placebo. That's a very important lesson. And it provides very good insight also on top of the genetics, which is to say that we've focused on getting LDL very low. And of course, that's important. What we've really not paid attention to is getting it low soon and not waiting. So if you want to optimize ASCVD risk reduction, it's not just the magnitude of LDL cholesterol reduction. It's also the duration of LDL cholesterol lowering. And that has led to this concept of cholesterol years. This is akin, of course, to pack years in smoking. We're all familiar with that. Somebody smokes 2 packs per day for 40 years. They have an 80 pack year exposure. It gives us some idea of the cumulative exposure to that toxin. It's the same thing for cholesterol. And that is the reason why individuals who have FH, where they have high LDL from birth, if it's not identified and treated, they cross the threshold for the development of ASCVD very early on, because their cumulative exposure is high early on. Versus those individuals who are genetically gifted with, say, loss function mutations in PCSK9, lifelong lower LDL. And they may never cross the line. They may never cross the threshold for ASCVD. So this concept of cholesterol years is sort of gaining traction and hopefully will translate into getting over some of this clinical inertia of starting individuals on lipid-lowering therapy earlier. So we reviewed the phase 3 cardiovascular outcome trials with the 2 PCSK9 inhibitors. We've known about those results for quite a while. What we're waiting for, though, is the next set of trials, which look in a slightly lower risk population. And we will see the results of this trial, VESALIUS-CV, very soon. This is also with evolocumab, but in a slightly, not a low risk group, but lower risk than what has been studied before. These are individuals with ASCVD, but without history of clinical events. So coronary disease with no history of MI, cerebrovascular disease with no history of stroke, PAD with no limb events, diabetes for 10 years or more, and even CAC can get you into this trial, CAC greater than 100. And so this is 12,000 individuals with an LDL cholesterol of 90 or more on background statin therapy, then randomized to evolocumab versus placebo. And we are going to find out the results very soon. Now, of course, the spirit of the development of these PCSK9 inhibitors was to lower LDL, but there are some interesting findings across other parameters, including looking at lipoprotein(a). One of the very consistent findings early on, even in the phase 2 LDL cholesterol lowering efficacy trials, was this very consistent reduction in lipoprotein(a) on the order of about 20 to 30%, quite modest, but quite consistent. And it didn't matter if you're talking about alirocumab or evolocumab. It didn't matter if you're talking about high dose or low dose. It didn't matter if you're talking about treating for a short time or long time, FH, not FH. You see it in everybody. Okay, all the trials. So I want to just take a tangent because, you know, lipoprotein(a) has become a hot topic, but many people may still not be that familiar. So let me just demystify some of the issues regarding lipoprotein(a). It's really just the cousin of LDL. It suffers from a terrible PR problem. The name is awful, and this has really gotten in the way of people getting to learn it. People just get turned off by that name. It doesn't sound like LDL, HDL, IDL, VLDL. But all it is, you see an LDL particle that's cholesterol-rich lipoprotein on the left. All lipoprotein(a) is that same LDL with this additional glycoprotein bound to it. That glycoprotein is called apolipoprotein(a) or ApoA. So an LDL plus ApoA is lipoprotein(a). However, lipoprotein(a) is probably a nastier particle than LDL because of the unique features of apolipoprotein(a). So let's dissect the genetic architecture of the LPA gene. The LPA gene codes for apolipoprotein(a). I have plasminogen on the top because the LPA gene evolved from plasminogen. Plasminogen has a protease on the 3' end, that's the business end of the molecule, and then it has these 5 Kringle domains named after this Danish pastry, which actually I had to try because I study lipoprotein(a). So there's these 5 Kringle domains. Apolipoprotein(a) is essentially a truncated form of plasminogen. It has that protease, but in the case of ApoA, it's inactive. And it only has Kringles 4 and Kringles 5. It doesn't have Kringles 1, 2, and 3. But it gets a little bit more complicated because Kringle 4 has 10 subtypes. Kringle 4 subtype 1, Kringle 4 subtype 2, all the way through 10. But to make it, you know, completely complicated, there is copy number variation in Kringle 4 subtype 2. So you might have 3 copies of Kringle 4 subtype 2, which would give you a small ApoA, or you could have 40 copies of Kringle 4 subtype 2 and everything in between. So there's this isoform variation. And to make this more tangible, on the top, you see a small isoform, the top left. You see there's only 4 Kringle 4 subtype 2 repeats on the bottom right, a very large isoform, okay? 40 Kringle 4 subtype 2 repeats. This is important because there's an inverse relationship between isoform size and plasma concentrations of LPA. As you might imagine, individuals who have the small isoform, the hepatocyte can synthesize that very efficiently. And so they'll have a lot of Lp(a) in their circulation. On the other hand, individuals with the very large isoform, takes time for the liver cell to make that, and they tend to have lower concentrations. And so there's this very consistent inverse relationship between isoform size and plasma Lp(a) concentrations. And this is the #1 determinant, genetic determinant of Lp(a) concentrations. And unlike LDL, that's determined by both lifestyle and genetics, Lp(a) is almost exclusively determined by your genetic architecture. There's some non-genetic factors, but they have modest impacts. So hypothyroidism will tend to raise your Lp(a). When estrogen wanes in menopause, Lp(a) will go up. Chronic kidney disease would be the most common. GFR goes down, Lp(a) goes up, and then in liver disease, it actually goes down. Importantly, there's a lot of people who like to debate this. Lifestyle measures, although extremely important in the individual with high Lp(a), because that lowers global cardiovascular risk, you still need to live a healthy lifestyle. But if you improve your diet and you do more physical activity, if you lose weight, it will have no material impact on your Lp(a). You need to do these things, but it won't lower your Lp(a). So Anurag actually published this beautiful review on apolipoproteins. This is a figure from this paper. And this illustrates why Lp(a) is such a bad actor. Well, for one, as we've talked about, Lp(a) has an LDL-like particle. So when an Lp(a) particle gets into your arterial wall, it's delivering the cholesterol cargo just like an LDL particle would. But again, it's the unique features of the ApoA that make it even nastier, which is to say that the apolipoprotein moiety appears to be a plasma repository, a plasma sink for oxidized phospholipids. Most of your oxidized phospholipids are on ApoA. So when it gets into the arterial wall, it's not only delivering cholesterol, it's delivering these highly inflammatory oxidized phospholipids, which amplify plaque inflammation and make plaques more vulnerable to erosion or rupture. And then finally, as I mentioned, it shares some homology to plasminogen. So at least in theory, has antifibrinolytic activity as well. So all of these properties make it a highly atherogenic particle. Now, unlike LDL, which follows a normal distribution in the population, Lp(a) is highly skewed. But 20% of the population, 1 in 5 people, and there's definitely more than 5 people here in this room, 1 in 5 people has a level that's putting them at risk for atherosclerotic cardiovascular disease and calcific aortic valve stenosis, but it's hiding in plain sight because nobody's checking it. 20% of the world's population is 1.4 billion people. This makes Lp(a) the single most common inherited dyslipidemia. And if you look at all the literature, this is becoming of interest as therapeutics are now in phase 3. You can still see that less than 1%, even in the United States, are being tested. So what is the relationship to coronary heart disease? Here's the epidemiology. This is from the UK Biobank, but I can show you any population-based cohort. It looks exactly the same. As Lp(a) goes up, so too does risk of coronary heart disease and calcific aortic valve stenosis. Similarly, the genetic epidemiology, genetically predicted Lp(a) is associated with higher odds for coronary heart disease and calcific aortic valve stenosis. And looking at the genetic determinants of coronary disease, the Lp(a) gene has the greatest magnitude of association with coronary disease versus any other genetic determinant. And the same is true also for PAD. So this is a very serious issue. So the observational epidemiology, the genetic epidemiology is very consistent, but of course we haven't been able to establish causality because we've never had really a tool to take high Lp(a) and lower it. But as you know, there are now 3 different drugs in phase 3 cardiovascular outcome trials, 1 to report next year. And these drugs lower Lp(a) between 80 to 95%. So hopefully we'll have something. So getting back to what I was saying before, there's this consistent reduction in Lp(a), 20 to 30% with the PCSK9 inhibitors. So you may see some people trying to get people on PCSK9 inhibitors who have high Lp(a) because at least it offers something, but we don't actually even know if Lp(a) lowering is a productive thing to do. I think everybody acted very surprised when all of this, including myself, wow, these drugs are the only things that lower Lp(a), but perhaps we shouldn't have been so surprised because those same individuals with loss of function in PCSK9 also had lower Lp(a) levels. So the genetics actually predicted this. So what have we learned from the PCSK9 inhibitor cardiovascular outcome trials? Here's again data from the Fourier trial, 60% reduction in LDL, 27% reduction in LPLA, and LPLA tagged those individuals who were most likely to benefit from the PCSK9 inhibitor. As you can see, individuals on the right who had a greater than median LPLA, they had a greater absolute risk reduction from the PCSK9 inhibitor. Now, that doesn't mean it's through the LPLA lowering, but they did get greater benefit from the therapy. I think what the Odyssey investigators do, take it a step further, which I think clinically is very helpful. They ask the question, is there a benefit of a PCSK9 inhibitor on top of optimized statin treatment when the LDL cholesterol is already pretty well treated, around 70? So this is a post hoc analysis of Odyssey outcomes. And important to realize that in that trial, there were screening LDLs and randomization LDLs. You had to get into the trial if one of those LDLs was 70 or greater, but 4,000 individuals on one of those readings had an LDL below 70. It was around 69. And the balance, the other 14,000 had an LDL greater than 70, was greater than 94. And then they stratified individuals according to above or below median LPLA. And I'm here just showing you individuals in the lower LDL cholesterol subgroup, because I think this is very interesting. So these are now individuals with an LDL below 70. And what we want to see is the impact of the PCSK9 inhibitor according to whether they had below median or above median LPLA. This is actually important. Median, remember, this is a skewed distribution. So even above median levels of LPLA aren't terribly high. And this trial, it's 13.7 milligrams per deciliter is the median. We consider high LPLA above 50 milligrams per deciliter. So even just looking at people on above the median, you can see that if your LPLA was low, lower than the median, there was no additional benefit to giving these well-treated patients a PCSK9 inhibitor. There was no reduction, further reduction in MACE. But if their LPLA was just a little bit high above the median, even though their LDL was 69, because they had an above median LPLA, they got further benefit from the PCSK9 inhibitor. What we've been talking about up until now is PCSK9 inhibition with the antibody approach. That's the upper right. This is a purely extracellular approach. You're blocking circulating PCSK9. And because PCSK9 is such a low abundance plasma protein, it's very easy to overwhelm it with antibodies. But now I want to shift gears and talk about a newer approach. This is a double-stranded small interfering RNA, which is an intracellular approach. And it's very clever how they engineered this. And all new lipid therapeutics that are antisense oligonucleotides or small interfering RNAs and other genetic approaches, they are all using this approach, which is to say they conjugate the drug, in this case a small interfering RNA, to something called GalNAc. GalNAc is N-acetylgalactosamine. The reason for that is its cognate receptor, the ASGPR receptor, is highly expressed on liver cells. So this allows you to give a little bit of a drug, and it's going to be just going to the liver, because that's where the receptors are. That's where you want it to go. That's where cholesterol is produced. Liver is the factory of cholesterol production. So what it does is, first of all, you're not getting this drug in all the other tissue, and it allows you to reduce the dose dramatically. And so what happens? Side effects, adverse events go down. So inclisiran, which is the small interfering RNA, is conjugated to GalNAc. So now what you have is it's directed to the liver. This double-stranded RNA is loaded into what's called the RNA-induced silencing complex, or RISC, in the liver cell. And this complex then binds to the PCSK9 mRNA, and that leads to its degradation and prevention of its translation into protein. It's basically degraded. But the beauty of this approach is that RISC is highly durable. So it's not like it destroys one mRNA and then it's gone. It destroys one mRNA and then goes on to the next and the next and the next for months. So very efficient, very effective. And this highlights the major differences between the antibody approach and the small interfering RNA approach, which we've talked about. But from a practical difference to patients and to us, the big difference is the frequency of administration. Most individuals who are getting the PCSK9 inhibitor antibodies are getting it twice a month. They do it at home, self-administration, very easy. The small interfering RNA approach is twice a year, every 6 months, but it has to be done in a clinic or in an infusion center. So here are the clinical trials. These are the phase 3 LDL cholesterol lowering efficacy and safety trials, Orion's 9, 10, and 11. Orion 9 studied patients with familial hypercholesterolemia. 10 and 11 were grouped together. This is patients with ASCVD or at high risk for ASCVD. Both of these papers were published in the same issue of New England Journal of Medicine 5 years ago. Now, they were designed with the same protocol, with the idea that they would be able to aggregate all the data and to gain more statistical power. So this is what they look like. They were 18-month studies, and these were obviously placebo-controlled, randomized controlled trials, one-to-one randomization, inclisiran versus placebo, and you get an injection at day 1, day 90, day 270, day 450. So it's injection number 1, then 3 months later is the second injection, and then you go to every 6 months. So in the first year, you get 3 injections, and then after that, it's only twice yearly. And so here's what I mentioned. Orion 9 is FH, Orion 10 is ASCVD, and 11 is high-risk patients. And here's the patient-level pooled analysis of the data. The baseline characteristics, individuals were about 65 years old, 40% from the United States, about 2/3 men, 40% with diabetes. Everybody's on lipid management, primarily statins. About 15% were on ezetimibe, and the baseline LDL was 111. And here's the main result. You can see that the time averaged LDL cholesterol reduction is about 50%, at least over this 18-month period. Looking at other parameters, as you would expect, a drug that's stopping translation of PCSK9, you see major reductions in PCSK9. This is circulating PCSK9, 83% reduction, nice reductions in non-HDL cholesterol, ApoB, and again, you see with another PCSK9 therapy, reductions in lipoprotein lay. Really, the only adverse events that are seen are all injection site reactions, and they're mostly mild, transient, and in the clinical trials, none were severe or persistent. Importantly, no evidence of liver, kidney, muscle, or platelet adverse events. But these are 18-month trials, okay, so very short term. Orion 8 looked at the open label extension of several of these clinical trials. So it basically added another 3 years to the observation. And this now includes over 3,000 individuals. You can see that the main result was about 80% of individuals attained their LDL cholesterol goals. So if your LDL cholesterol goal was less than 70, you got to 80%. If your LDL cholesterol goal was less than 100, about 80% got there as well, and no new safety issues. So what do we have here? We have a new therapy, a new approach. It appears to be durable and potent LDL cholesterol reduction with an easy administration frequency. Safety looks good. But really, the promise of this kind of approach is potentially to improve adherence, because that's what we all struggle with, right? We have all these great drugs, but if you can't adhere to it, it's a major problem. This is some work that we did recently that showed that less than a quarter of people in the United States are getting to their LDL cholesterol goals. I mean, this isn't any news. I mean, Da Vinci, which is the big European registry, shows exactly the same thing. Less than 20% of people. It's even worse in people with ASCVD. And this is a major problem because these drugs only work if you take them, right? And this is a really poignant demonstration of this. This was a very interesting analysis that basically categorized people as being fully adherent. They took this is statins, they took their statin more than 80% of the time. Partially adherent, they took it between 40 to 80%. And non-adherent, they took it less than 40% of the time. And you can see on the right, whether you're a post-MI patient or patients with stable ASCVD, if you were in green, if you took the statin all the time, you had significantly lower event rates. But if you were partially adherent or non-adherent, of course, event rates were much, much higher. So I think a very nice demonstration of how inclisiran can be used to improve care was the Victorian Initiate trial. This was actually presented at the ACC 24 and simultaneously published in JACC. And essentially they evaluated this inclisiran first implementation strategy. So they took patients with ASCVD who were on statins, their LDL was still greater than 70, and they said half the group is going to immediately get the addition of inclisiran, and the other half is at our discretion. You can guess what we did. So this is 450 individuals, 225 get the inclisiran, 225 get usual care. And here's the baseline characteristics. Again, mean age is 66, 30% female. LDL here is 97. These are ASCVD patients, mostly getting statin monotherapy, but essentially everybody's on a statin. And you can see no surprise here, right? So the time averaged LDL cholesterol reduction, placebo-controlled, was 53%, favoring people who immediately got the addition of inclisiran versus the people who were at the discretion of their clinician. And that's because we all have, if we leave it to our discretion, we all have a lot of inertia, right? And that's why there's this big difference. There was some concern amongst the investigators that for the group who was randomized to inclisiran, they might discontinue their statin. So they actually had this statin discontinuation as an outcome. And you can see there was no statistically significant difference in discontinuation between the two groups. And in fact, it was numerically fewer discontinuations amongst the individuals who got the inclisiran first strategy. In terms of LDL cholesterol goal attainment, if you immediately got the inclisiran, 80% got to their LDL cholesterol goal. This is an LDL cholesterol less than 70 versus about 20%, which is what we see in all the registries. But of course, many of us are now going for an even more aggressive LDL cholesterol goal, less than 55. Pretty impressive. 70% of individuals who immediately got the addition of inclisiran got to that LDL cholesterol less than 55 versus essentially nobody if you left it up to the clinician discretion. And here are the other lipid parameters. Again, a significant reduction in lipoprotein lolate. So I think this inclisiran first strategy, is impressive. Significantly reduces LDL, significantly increases goal attainment, did not lead to statin discontinuation. But I think the real promise again is it may just help us to overcome this therapeutic inertia. And by getting patients on a therapy, which is quite easy, twice yearly, you're going to get all of these patients to goal, and it's very safe. Of course, we're waiting for the cardiovascular outcome trials. What I've shown you is LDL lowering. I've showed you safety. We don't have any cardiovascular outcome trials. But I think most people who believe in the LDL hypothesis would suggest that if you have a safe drug that lowers LDL effectively, you would anticipate an improvement in MACE, but we'll have to wait and see. There's actually 3 outcome trials that are ongoing. The major one is Victorian 2 Prevent. This would be the inclisiran equivalent of FOURIER. That was the evolocumab trial, exact same design. Patients with ASCVD who had prior events, prior MI stroke or PAD, who are on high intensity statin LDL still above 70, then they're randomized to inclisiran versus placebo. Duration is 5 years. 14,000 individuals will see these results soon. But like with every new therapy, even though there are trials that we have that were not powered to look at events, nobody can help themselves but to look for events. Fortunately, at least this is, in the right, on the right side. So, they looked at the phase 3 trials with inclisiran, primarily Orion 9, 10, and 11, and you can see 26% reduction in MACE favoring the use of inclisiran versus placebo. Okay, at least it's going to reduction and not increase in events, but I don't know what we can really make of that. And now I want to get into some more interesting things, which is to say that this is an abbreviated list of what's in the pipeline for PCSK9 therapeutics. Now, you'll remember I made kind of a snide remark when I was talking about the PCSK9 inhibitor monoclonal antibodies, like, why are we starting with an antibody? Like the most expensive approach, right? We always start with small molecules, okay? Well, of course, the field also started with small molecules with PCSK9 inhibitors as well. The problem is they all failed. And the problem is it's very difficult to disrupt a protein-to-protein interaction because what you're trying to do is disrupt PCSK9 protein from binding to LDL receptor protein. Those protein-protein interactions are generally flat and featureless. It's hard to drive a wedge between those. But through advances in medicinal chemistry, it is now possible. One approach is this macrocyclic peptide called imlicitide. This is now in phase 3, but here's the phase 2b dose ranging study of several doses of imlicitide versus placebo. And you can see at the higher doses, 60% reduction in LDL cholesterol with a once daily oral PCSK9 inhibitor. Okay, that's exactly what the antibodies give you, 60% reduction. And this is the phase 3 program. There's Coral Reef HeFH, of course, that's studying this drug to lower LDL in patients with familial hypercholesterolemia. Coral Reef lipids, also LDL lowering efficacy and safety, and just garden variety hypercholesterolemia, and the outcome study, which is a very large study, which we anticipate in 2029. But probably the most fascinating approach, which you may have heard about, borderline science fiction, is the prospect of using gene editing approaches to permanently lower LDL cholesterol. So you may know some of the advances in CRISPR technology. There's even therapeutics out in the market, sickle cell, I mean, a major victory, especially for such a devastating disease. There are a lot of gene editing approaches going now for lipid therapeutics. I'm talking only about one approach here, and I'm only talking about an approach that's doing editing of PCSK9 because there are other lipid genes that are being approached. Okay, so keep that in mind. But I'm talking about a very interesting approach because it's not gene editing, it is single base editing. Change one DNA alphabet letter to cause a permanent loss of function of PCSK9, permanent reduction in cholesterol, one infusion, and your LDL stays low for the rest of your life. Who's signing up for that? I'm not signing up just yet, but it is very interesting. So here's the original data in monkeys. This changes in adenine to a guanine. Okay, so you basically cause a premature stop codon in the PCSK9 gene, which is different than the naturally occurring loss of function mutations in PCSK9 that I talked about before, where there's still some preservation of PCSK9 function. This is knocking it out. Okay, and you see 90% reduction in plasma PCSK9, 60% reduction in LDL cholesterol in these monkeys. Of course, what is the nightmare scenario? Off-target editing. We don't want to edit the germline. We just want to cause a somatic mutation in liver cells in that one gene. So, of course, there were very detailed analyses. Here's one such analysis. This is now looking after about a year and a half. They looked at the sperm samples from treated male monkeys, and they looked at the offspring from treated female mice, and there was no evidence of germline editing of PCSK9. We're not looking to carry this on to the next generation, okay? Just in the patient in front of you. Again, still monkeys, 3 years, looking good. PCSK9 is still knocked down, 85% reductions, LDL cholesterol reductions over 60%. The safety and efficacy supported first in human trials. So this has been already dosed in humans. The first drug is VERV-101. It's basically the genetic material. The editing device is within a lipid nanoparticle that's infused for a few hours, binds to the LDL receptor, gets into the liver cell, and again, single base change. This is the first results, dose ranging study, but I'm not going to get into the details because there were some problems. One of the patients had very profound ALT increase and very severe thrombocytopenia. That trial was halted. The team had to figure out what was the problem. Their suspicion was it was the actual lipid nanoparticle. They re-engineered it, used different lipids on its surface. They also put some ApoE on it, and conjugated it to GalNAc so that it not only got through the LDL receptor, but it also got through the ASGPR receptor. So again, you can use lower doses. So this is so-called VERV-102, this re-engineered base editor. And it's, in monkeys, they obviously had to go back to monkeys, nice reductions in LDL cholesterol. Now back in humans, they're in the Heart-2 trial, dose ranging study, and the initial data from the first dozen is expected in the next few months. So very, very exciting. So I've taken you through kind of the evolution of PCSK9 in therapeutics. Of course, this all started with statins, small molecule inhibitors, but we've gone through antibodies, small interfering RNA, macrocyclic peptides, and now potentially base editing. So a lot going on, very exciting. And I'll conclude and hope you'll agree that really the discovery of PCSK9 has really transformed our ability to take care of patients with severe hypercholesterolemia and patients at high risk for ASCVD. As we've talked about, the antibodies have already demonstrated to improve outcomes. The small interfering RNA approach, very convenient, safe and effective. We're waiting for the outcome trials. And as we've just talked about, some very exciting additional approaches to antagonizing PCSK9 are in development. So I'll conclude there and be happy to take any questions.
Great talk. Thank you very much. If we're talking about reducing the protein for years at a time or months at a time or a life, are there any forward effects of depleting someone with PCSK9 other than, you know, of course, we want the LDL benefit? Does it work anywhere else?
Right. Well, to make you feel uncomfortable, the original name of PCSK9 was NARC1 because it was discovered in the brain. So it does have some function in neurology, although the lion's share of PCSK9 is, of course, produced in the liver and the kidney. I think what really gave confidence that this would probably be a safe approach is the R46L, loss of function variant is relatively common. 3 or 4% of the population is walking around with this. And these people have no, as far as we can tell, nothing other than low LDL and lower risk of cardiovascular disease. No other signals. Even in individuals who are homozygous for loss of function of PCSK9, who are walking around with essentially no PCSK9, perfectly healthy, and there's no issues. But you're right. I mean, we've had the PCSK9 inhibitors got approved, the monoclonal antibodies got approved in 2015. So we have a decade of experience. So of course, there's still lots to learn. But thus far, looking at human studies, genetic studies, nothing has surfaced. Yeah, great question though. Yeah, great.
Great talk, and thanks for making the trip up. It's great to see some of the Wake Forest stuff. I loved your slide on LDL lowering over a lifetime.
Mm-hmm.
So I'm wondering, are there any results where we start to think about, and not just with familial hypercholesterolemia, but we start to lower LDL as a teenager or 20-year-old? So that's question one.
Yeah.
Question two, you mentioned that only 20 to 25% of the world's population even embraces this concept and wants to get after it a little bit or follows their therapy. What is the main obstacle there? What is the resistance to addressing this? I mean, it's got to be more than just taking your medicine every day. So I'm just wondering what your thoughts are on those 2 points.
I'll start with the second one first. I should have included this slide. This is a real study, but there's a very close relationship between access to Google and statin intolerance. I'm not joking. This has actually been studied. It's a straight line just like that. So I do think that misinformation definitely plays a role. I mean, to your point, it can't explain it all. I do also think that statins, in terms of the side effects, they're real. You'll hear people talking about, real versus perceived, and they just think they have side. I think that if you look at all of the real world data registries and some observational trials, true statin intolerance is probably about 30%. I'm not anti-statin, of course. Statins have, changed everything in terms of, ASCVD risk reduction. It started everything off. But it is truly an issue, the tolerability. And, taking a low dose statin is a great thing to do, but it's not going to get your LDL to. What we now understand is you need to have much lower LDLs than we originally thought. And to the first question, you need much longer. So, there was a recent RFA that we responded to from the NIH about a trial looking at using statins or lipid therapeutics in general in younger people. Now, they didn't say teenagers. This was more like 30, 40, 50-year-olds. So that's a start. The major barrier is if we can't get people who've had a heart attack to continue taking statins, and they don't, at least that's what the data shows, there's no way you're going to get an 18-year-old take a statin for 50 or 60 years. The truth is you probably don't need to take it your whole life. There's probably a critical window where it's really important to keep your LDL low. And there's much more benefit more proximally to LDL lowering. So it could be the case that all you need to do is take inclisiran twice yearly shots between the ages of 20 to 40 or 20 and 50, keep your LDL pretty low. And then perhaps you can go off of that and something else is going to kill you when you're 80. Because if you keep your coronaries clean until you're 50, it's going to take a while before you develop plaque and suffer the consequences, right? So it could be the case. Now, that all of these things are very difficult to study because your proposed study in young people, which I love, can't be done because you can't observe these people for that period of time. It'll break a budget, right? So, and you'd also have attrition in the studies. So it's a very difficult problem. And I don't think society actually even has the appetite for it, putting large proportions of young, healthy people on lipid-lowering therapy. Even if we had the data, I don't know if we have the appetite for it. It's a real problem. I don't know if that answers your question.
No, I just think it's something to think about because you just made a very convincing argument in your paper about over time. And, after the event, a lot of this is secondary prevention, and so we're thinking about a strategy of primary prevention. Where's the main issue? Is it education? Is it learning? What's going on in the community? What are they thinking about this? Things like that.
Yeah, great point.
Yep, thanks.
Any questions
Hi,
from
Doc.
online?
Hi, Dr. Shapiro. This is Arun. I'm one of the first-year cardiology fellows. Thank you for your talk. Sorry I couldn't be there in person since I'm at the VA. I have three
Arun?
questions.
You might need
Yeah.
to speak up.
Oh, can you hear me now?
Yeah.
Okay. I have three questions to ask. The first question is, are there any risk scores in the pipeline that would indicate early initiation of PCSK9 or inclisiran? The second question is a more clinical based question. If I have a patient that comes in with elevated LDL, high risk factors, but straight wants to start PCSK9 or inclisiran rather than statins due to ease of use and higher LDL lowering capability, how would we tackle um, insurance, or would it be more of an off-label use, or would they have to pay out of pocket? And the third question would be, has any study looked at the change in plaque morphology in patients that have been started on PCSK9 or inclisiran?
So I'll start with the last one because that's the easiest of your questions. There have been detailed IVUS and OCT studies in patients on PCSK9 inhibitor trials, and they show all of the favorable changes that you would anticipate from very aggressive LDL cholesterol lowering. So thicker fibrous cap, lipid depletion, less inflammatory cells, and that of course is clearly associated with improvements in outcomes. So that is tightly associated. With regards to, can we skip the statin and just go to the good stuff? I mean, it's a similar problem we have with treatment of diabetes. I take care of a lot of patients with diabetes. I use the newer therapies all the time. Do we really need to go through metformin first when there's such clear evidence of benefit from, GLP-1 receptor agonists and SGLT2 inhibitors? It's going to take the guidelines to get past, all of the randomized controlled trials are structured on a hierarchy of history, right? So all of these trials are based on statins. And so, the way the guideline system works is, you have to read from the evidence, which was, well, these patients were on statins and so forth. But this is a controversial statement. Some people in the audience may not like this, but I'll say it anyway. There's nothing magical about statins beyond their ability to lower LDL cholesterol. So you'll hear a lot about pleiotropic effects, magical properties of statins. And yes, you can demonstrate all of those in a test tube. Lots of positive things. Right. But if you plot LDL lowering versus events, and this has been done by the Cholesterol Treatment Trialist Collaboration and all the new drugs, ezetimibe, PCSK9 inhibitors, bempedoic acid, all the drugs that have outcome data, if you plot the proportion of LDL cholesterol reduction to MACE reduction, you see exactly the same slope. So if there was something magical beyond the LDL lowering of the statins, you would see a different line, but you don't. It's all in the LDL cholesterol reduction. The problem, as you mentioned, is cost. That's the problem with antibodies, because even over time, even though cost has come down, you will never be able to produce antibodies inexpensively. That's a very tedious process to produce antibodies. Right. What I can't understand is why small interfering RNA is priced more expensive than the antibodies, because that's a very inexpensive approach. And from a practical standpoint, is going to be much better, and also gets into the issues we talk about. Maybe if you could, I didn't mention this, but it's been modeled. In primary prevention, if you give inclisiran once a year to your healthy 25-year-old, right? Right now we're giving it an ASCVD twice a year, you get 50% LDL reduction. If you give it once a year, you get about 38 to 40% reduction. that's great. That's moderate intensity statin. Once a year,
Right.
get it with your flu shot. And that takes care of ASCVD. You get every 20-year-old for 20 years to do that at a population health level, you're done. So I think some of
Yeah.
these innovative solutions hopefully will come into the fore. But you're right. I mean, right now, we're all battling with insurance companies, even for individuals who, meet all the criteria perfectly, so it's very, very difficult. But I would say that if you can get it approved, there's no reason if a patient prefers Repatha, why they can't take Repatha. It's easier, it's more
Right.
effective, less side effects. It's just without, even trying a statin, it's going to be difficult to get that approved, but I have no objection to it.
Got it.
And your first question was, are there risk scores to predict which patients would benefit the most from a PCSK9 inhibitor?
Yes, that is correct.
No. You may know that there's a new kind of ASCVD risk estimator, the PREVENT equation, which will probably replace the pooled cohort equation in the next cholesterol guidelines, which will be out next year. But that's just looking at 10-year and 30-year risk in ASCVD, heart failure, and composite cardiovascular disease in individuals without known cardiovascular disease. So probably a very different question than you're asking. So I think the answer to your first question is no.
Got it. Thank you so much. I appreciate it.
Certainly.
Just to follow up, do you foresee, just like we give pneumovax to people who get admitted for bronchitis pneumonia as they just get discharged from the hospital, that anyone with heart failure, ACS, MIs, before they go home, they get a shot of, the small molecules?
Yeah, that's being studied for both the antibodies and for the small interfering RNA. For the antibodies, it's already been shown as proof of principle that you can do it and it lowers LDL safely. We don't have the outcome study yet, although we will have that soon. And it's still earlier for the small interfering RNA. But I imagine, it gives you a lot of, one of the things we all struggle with, right, is somebody got admitted for ACS, and then you have to get them to the first appointment, right? And they had problems getting the drug, or they had side effects or whatever. And so they're going for a few months, maybe without getting LDL cholesterol reduction. You give them a shot of saying, inclisiran, they're good for a few months. And it takes some of that pressure off. So I do imagine a day where we'll be doing that. Yeah.
What's the role of these drugs in terms of inflammation, measuring markers of inflammation?
Very interesting. And you may be asking because the statins have consistently demonstrated 30 to 40% reductions in hsCRP,
Right.
No reduction with the monoclonal antibodies. But that's measuring circulating levels, right? Systemic inflammation. Plaque inflammation definitely goes down, and that's probably where it matters. Yeah. But hsCRP is not a good surrogate of what's happening in the plaque. Okay, thank you very much.
Very good.
Yep.
Thank you.
Thank you very much.